Hello, and welcome to the Critical Path Institute podcast. Our goal for this podcast is to connect the dots among our core competencies in regulatory science, biomarkers, data management and standards, clinical outcome assessments, and modeling and analytics, and how we accelerate drug development. CPath created this podcast for researchers, clinicians, and industry and regulatory professionals with the hope that these conversations and the resources we share will advance your efforts and partnerships to improve global health.
Okay, welcome everyone to another episode of CPath's podcast, where we connect the dots between science, clinical medicine, drug development, and the patient's voice. Today I have with me one of our vice presidents who leads everything rare and pediatrics at CPath. Collin, please introduce yourself.
Sure. I'm glad to be here. Thank you for having me, Klaus. My name is Collin Hovinga. I'm the Vice President for Rare, Orphan, and Pediatric Diseases at Critical Path Institute.
Great. So that's a long title. It covers rare diseases and pediatrics. Let's start with the rare disease side of things. There's a couple of different definitions of what a rare disease is. Can you walk us through what the U.S. definition is and the European definition, and how we treat those definitions as opportunities at CPath?
Usually when we think of this, it really is a reflective of a population within the U.S. Generally, it's less than 200,000 cases within the population, and so it's a relatively fixed number of patients within the population.
Yes, and with those numbers, you may think, well, those are diseases that are infrequent. But if you add them up, they're number one, a number of conditions that add up in numbers, but also in underlying mechanisms. Can you comment on that a little bit?
Yeah, so one of the things that people don't appreciate is that about 10,000 different rare diseases exist, and it's estimated, and this number seems to increase as we further understand the mechanisms behind diseases. And so even though we may originally have classified a disease as one type, we're realizing that there's many different subtypes of those that actually have different progressions and slightly different mechanisms as we begin to understand the molecular pathophysiology of them.
And the as you say, the pathways that the diseases have relate to the mechanism of disease. And even though the clinical presentation may vary, a lot of those underlying disease mechanisms are common. So if you look at them from that standpoint, the numbers then take a different light. Can you comment on that as well?
Yeah, definitely. And I think that now, people are starting to think of diseases much differently because the pathophysiology of disease and mechanism of disease offer additional opportunities of how to study them and to look at their progression and whatnot. And so you're seeing, things like tauopathies, and things like where we're looking at genetic carriers that have common foundations in order to better understand how the similarities and differences that they might have in designing clinical trials, particularly innovations in trial design methodologies that are unique to rare diseases and such.
Oh, great! You moved in a direction that is definitely important, because there's the saying, rare diseases are not rare. You can see now why. But let's talk about how that represents a significant opportunity to accelerate drug development, which is a core tenet of our work here at CPath.
One of the things that we do is we define solutions with communities that include regulators, sponsors, advocacy groups, patients, and we define where the gaps and what they need to create solutions that are meaningful to patients and access, and provide access to treatments and such. This is a really well thought out process, and we've done this for really about 20 years now. So we've become recognized and trusted to do this with various communities and such. We've drawn what I would say is even more prominent in rare diseases because the emotional element and the connection with the communities is important. And so we've invested in more PFDD or patient-focused drug development elements, both in our COA program, but also we have a director of outreach within CPATH that works with communities to foster and connect with them to make sure that we're really, having the voice of the patient involved in all of what we do, because as you all know, is that if a treatment doesn't reflect something meaningful to those that receive it, obviously it's not, something that's valuable to those that are most impacted by a condition.
Yeah, great. And thanks for the shout out for everyone that listened to the episode that we recorded with Cheryl Kuhn about the patient-focused drug development construct. But let's build on an important aspect that you mentioned about the communities that live with these conditions. They certainly have a drive and a desire to contribute to scientific research and drug development, but they also want to make sure that the data that they contribute to that research has maximum utility. And that's where our rare disease data and analytics platform comes into play. Can you connect those dots for us?
We also call that RDCA-DAP, just so everyone on the call can listen to. And if you get to refer it and people ask you, you can use that and people will know what you're talking about. One of the things that's recognized in rare diseases is that, there's a quote that you can go fast if you go by yourself, and if you work together, you'll go farther. And I think RDCA-DAP really echoes that. RDCA-DAP is a platform that contains, really well standardized and curated data amongst lots of different types. It is both like a library for data that's shared with the communities, and it's composed of things like registries, natural history studies, clinical trials, you name it. We've had lots of different data types. Why is that important? Well, one of the things that comes back to that is that the reusing information allows us not to have to repeat it again. And obviously, in rare diseases, given the diversity and number of this, obviously our time, talent, and treasure, is one clear element, and our most important element is the time to get treatments for many of these diseases as they are progressive. And so anything that we don't have to redo or we can learn upon and build on, it's an essential element to success. And so we believe it represents a bit of a community resource that can help maximize the efficiency of how we would deliver more rapid treatments to individuals. The other element that RDCA-DAP harnesses is that the ability to create solutions. So it's not just a resource, but it's something that helps us build answers that things that minimize the sample sizes in clinical trials. It can support the use, and it has supported the use of alternative controls leading to drug approvals. It can create simulation tools that can really generate more effective clinical trials, and even help decide decisions of whether or not the trial should actually even be done using information collected through that. And so it's a very powerful resource and such. And one of the things that comes back to the comment about engaging stakeholders, we do have what we call task forces within our RDCA-DAP that really convene individual stakeholders, including patients and sponsors and such. But the goal is really to be very targeted, quick, and agile to create solutions with them. And so, that function really embodies that, all the way from the library function to the generation of the tools as a really way to be impactful as a program.
Yeah, that's such a fantastic way of connecting a lot of dots. Another shout out to the episode that we recorded with Ron Bartek, where we talked about a very specific disease, Friedreich's ataxia, that benefited greatly from RDCA-DAP. But let's dive a little bit deeper into the tools that you mentioned, the solutions that can optimize clinical trials, help identify new ways of thinking about the recruitment of individuals, the characterization of the disease. We have a number of examples there where the platform that allowed the integration of patient-level data across diseases that supported then the generation of quantitative tools for acceleration of drug development has had an impact on a number of diseases. That's great. I'd like you to comment on that, but also how those quantitative tools connect with each other and teach one condition to another condition, how to think about those connectivities and the progression and characterization of diseases. Can you comment on those two aspects?
Yeah. The first aspects of our drug development tools, one of the things that before I joined CPATH that I appreciated how long it took to go negotiate and work through a clinical trial, everything from selections of endpoints that were acceptable for regulatory use, and to creating a statistical analysis plan and trying to figure out how many patients might be involved in a study, whether or not a biomarker might be useful for supportive evidence and such. And that's one of the things that CPATH does, is it works through addressing questions to support clinical outcome assessments, biomarkers, and clinical trial simulation and whatnot that would support the statistical analysis plan. I can give a little bit update on a couple initiatives within RDCA DAP that are related to what I would consider more obvious tools. In addition to the example that Klaus noted and Ron Bartek most likely spoke of, we're developing a trial simulation tool with Friedreich's ataxia. And one of the things that's really important about that is that we work really closely with the community, but also with regulators to understand even the key clinical questions about how the outcome assessment that was being used and how it reflects and how it changed across the different age groups that are now being considered in clinical trials. And so, we're addressing questions with the data that aren't just questions that were raised within there. They're questions that the FDA and the regulators have questions there themselves, and they're anticipated in excitement some of the information that might come of that, because the age groups that are being considered, for study are increasingly going down and lower, and how obviously having very clear defined understanding of how an endpoint performs in the different age groups is critically important to the success of a therapy, or even how you might consider things like extrapolation or combination studies for future drug studies in that indication.
Yeah.
Keep going. Then we have others in other simulation tools that are going. The other one I'm going to say that's a little more subtle, and I really, when I first came to CPATH, I didn't fully appreciate the value. I did and I didn't, and I'll say, because it's one of the things that you imagine if you were to take a disease. We talked about different mechanisms a bit ago in the first part of our conversation. You take lots of different data from lots of different diseases under one umbrella. And so we have an initiative under mitochondrial disorders that represents probably, I would say, maybe 50 different types. And they all have different way of data collection strategies. There's lots of heterogeneity in what data is being collected in that community. They have slight phenotypic and clinical presentations and such. And what we did is we worked in a task force to say, okay, let's begin to map out what our data standards should be. What is the common currency and language that we all should be taking? What should we be collecting that's meaningful to patients and researchers and for regulatory use? We recently submitted for review a paper to the FDA for them to look at, and they've provided very useful comments, and you'll see that shortly, that really makes a set of recommendations and reflect both of the conversations with the task force, but all the members in that community, and lots of different stakeholders representing different aspects of mitochondrial diseases. So one might not think of that in a traditional drug development tool sense, but the standardization and common language and currency of that data for aligned but slightly different diseases is really, really important. And I want to come back to one thing that links some of the other part of what you just said or asked. One of the things that I also learned to really appreciate when I joined CPATH was the rare diseases programs within the organization have just this great wealth of institutional memory. And one of the things before I was hired is that one of the things you immediately go to is regulatory precedent. How does this done before? How in this disease or that disease? And you had to go and research it up, try to figure it out. Does it apply? Does it or does this not apply? And one of the things that's just a powerhouse of knowledge at CPATH is that you can go to another consortium or another task force and say, okay, well, how did this unfold? And there's a lot of lessons learned and experience that we garnered from this. And so we sometimes think about common themes or concepts in a disease, and whatnot. And we're starting to discuss this in motor aspects of many progressive neuromuscular and neurodegenerative diseases right now. And so it's an exciting way to apply that. And we have different efforts focusing on that currently.
Awesome. So let's recap a lot of the dots that you connected there. So the patient experience and their willingness to maximize the power of the data, the existence of a data platform where data can be integrated in a standardized way, the generation of tools that can transform and accelerate drug development based on those data, the examples of how approvals have been materialized thanks to that journey, the first disease-modifying treatment for Friedreich's ataxia, the first disease-modifying treatment for polycystic kidney disease, the first non-steroidal option for all variants of Duchenne muscular dystrophy. I mean, those are really, really powerful examples. But you mentioned something that is really, really important, the regulatory engagement, participation, and interaction that happens at CPATH, but also the visionary idea that they had in the first place in 2019 when they approached us with the idea of setting up this data analytics platform in the first place and the funding that they have provided to make it happen. Can you help us connect all those dots as well?
Yeah, I mean, it was, from my understanding, it was a back of the napkin kind of conversation that came from FDA, and we're very thankful for their partnership. I mean, it's, our interaction and engagement with the regulators at FDA have just been amazing. We consider them really strong allies and collaborators, and their support has just been part of our shared success. And it's one of the things that I would say makes us unique, because they're not just colleagues. The passion and collaboration that comes for helping us work through problems is just a key element in I guess a secret ingredient. And it's not one party, it's the synergy that comes with the two lenses, because one of the things I think the agency leans on us for is we're allowed to go into lots of different stakeholders and have very candid conversations, and then talk to the agency to both help clarify questions, but also to say, okay, let's really look at this. What does the solution look like, and how do these different voices come up into something that comes a treatment ready, kind of solution, so that everyone is working towards the same goal. And I think the commitment from our organization and obviously representatives at FDA is just such an empowering element. And I think I always consider them a little bit unsung heroes, because they may get a bit of bad press all the time and such, but they're just so compassionate and so energized into supporting our programs and the communities that we represent.
Excellent. Now let's talk about a type of rare disease in particular, rare neurodegenerative diseases, and one that stands out, which is ALS, so Lou Gehrig's disease. The piece of legislation, the Act for ALS, that was signed into law at the end of 2021, is a visionary piece of legislation, because it really empowers FDA and NIH to work together in accelerating drug development for this type of conditions through the support of organizations like CPATH, and we were selected to be part of that collaboration. You lead that aspect of our support for the Act for ALS through RDC-ADAP and our Rare and Orphan Disease Program. Can you comment on how that connects with the data, the patient experience, advocacy, and the impact that we're having there?
Yeah, definitely. The Act for ALS was passed, and I want to say it was a very insightful and impactful legislation, and it really, to me, really represents an innovative structure. I know we as we talk about it, in many instances, each of the parties that are involved in this normally kind of do their thing. I mean, NIH goes and does a lot of basic science. They do some natural history studies normally, and FDA approves drugs. There's some crosstalk there. CPATH works with FDA. FNH works with its partner as well. And what this has done is create an ecosystem that includes the sponsors and patients and researchers all working in sync and learning from each other. So basically there is a natural history study called LALS that's collecting data. CPATH work with them and FDA to talk about what should the endpoints being considered, what DHTs should be included, where's the evidence there. And we're collecting them and learning from them, and in parallel working, on solutions that are being done and created and identifying gaps with those that the ready-made data will be able to go on and produce solutions, but also the gaps would fed back into, in a sense, the natural history study to fill those gaps. And so there's this learn and confirm paradigm that goes on. But historically what would have happened is, say, a natural history study would be done, papers would get published, but they might not have that little extra, information that would be needed to support their use, the data from that in regulatory use or whatnot. And so having this dialogue between the stakeholders to say, hey, if you tweak this design, this would actually make it much more impactful from a regulatory use case. And so having all of these stakeholders at this table is just such a powerful strategy. And I'd love to mirror this and beyond that. One of the things that's important to this is, obviously we have many, many, many working streams for this, and all of them involve the patient community. We have a community that is really supportive of this initiative. We have a working group that includes them in themselves, where we have dialogue to make sure we all stay on target and are doing the things that are meaningful for them. But also we have them included in our working groups. And so, one of the things that has impressed me, in addition to the support, is here you have a very progressive disease, but these people see the value of this and are willing to give their time and insights to support things that will benefit people even beyond their lifespan. As aspects of the data, one of the things that I am a bit proud about, and this was a really impactful statement from the FDA and their belief so much in CPATH to even advocate for us to be part of the data owners for the Act for ALS and what's called the ALS Knowledge Portal. It was clearly recognized that our skills in curating and standardizing novel data types around clinical data, particularly for regulatory use case, was something that was deemed really important. And so we form one half of this knowledge portal that's being created for the ALS community of researchers and sponsors and such. And so amalgamating and standardizing this data and making it most useful and connecting data in novel ways is something that I would say the NIH has not normally done before, and they've looked to us even about learning more about the curation processes that we do, because it is very aligned towards using it in regulatory use cases, which they don't normally consider.
That's powerful, for sure. Now, we talked about the public-private partnership approach. So we talked about the patient communities. We talked about the researchers. We talked about the regulators, importantly. Now let's talk about the other actor in that ecosystem. Let's talk about the pharmaceutical industry and how they participate in RDCA-DAP, our efforts to support the Act for ALS, but also the important participation that they have across the different consortia that we also have in specific rare diseases. Can you comment on that as well?
I mean, that's one of the other beauties at CPATH, is that we can have candid conversations with directors and even CEOs of pharmaceutical companies to understand, okay, what was the heartache or headache that you had when you were in regulatory discussions, because that solution hadn't been developed, or may require you to do lots more additional research, which further would delay a product's development and access to patients. We don't, just to be clear, we don't speak to things that are around specific drug products, so we stay in what's called the non-competitive space. And you can almost think of CPATH as, I would say, a public health organization, because we're really focusing on taking that one stakeholder, but addressing a problem that's really more of a public health problem. So, for example, if there's a lack of a good endpoint or a biomarker or lack of understanding of how those fit into a regulatory context, from regulatory discussions, CPATH can go and begin to think about how it could produce the evidence and the documentation and such to support a decision that could make it more impactful. So, sponsors regularly contribute their expertise, but also their needs as well. And what's unique about the public-private partnerships and our role as a neutral convener is that we listen to all of the parties at the table when we try to come up with a solution that benefits the broader community, and that takes into all those individuals' accounts. What's unique about pharmaceutical companies is that they trust us enough not only just to share their data, but they also trust us to share information that is just the things that are their frustrations. And you can imagine if you have multiple companies in an ecosystem that you're working in a particular disease, is that normally they're not going to go to another company and say, hey, I just left my type B meeting at FDA, and these are the things that were really hard for me. But they trust us enough to do that so that we can take all of this information together and say, okay, this is the path forward. We've heard all of these comments. This is the recommendations. This is our unifying scientific plan that we've provided input from patients, sponsors, regulators, and clinicians. We all move in lockstep, to moving forward. And back to the comment or quote I made earlier is that by doing that, you go far, right? You may not go as fast as an individual might, but you definitely can go far. And what we want to do is create milestone impacts, things that really, and CPATH has done that. I mean, if you look at our track record as an organization, we've done lots of firsts, and I think that is what is embodied by that approach.
Yeah. That was awesome, Collin. Thanks for sharing that, because it really connects a lot of the dots around the value of having a data and analytics platform, like the nature of the platform that we have. Following the drive to address unmet needs that regulators have, that patient communities have, that the pharmaceutical industry has as well, and do it in a public-private partnership way, in a neutral way, by starting the integration of data that may come from the pharmaceutical industry in the form of clinical trial data, may come from the patient communities in the form of patient registries, may come from academia in the form of observational studies. And all these data sources play an important role. But now let's talk about the future, where you see the future of the data analytics platform, some of the aspects of how the platform has also become a beacon for non-rare diseases to also integrate data into the platform and make those transformations, but where you see the future going in this journey of growing the platform and strengthening the platform.
I mean, I'll come back to an initial comment that I said that's important, irrespective of rare and non-rare, is that every precious data point counts. It's, having to redo something or to invest time means another year, 2 years, 3 years of time that's passed before you have evidence to support a decision or foundation of knowledge that allows you to do a proper study design or be able to generate evidence that's really important. So, one of the things that, coming back to an earlier comment, is that these platforms allow that history to be created and preserved and whatnot. So obviously we've focused on specific data types early on with CPATH, but the sky's the limit now. We have AI now. We have lots of different, natural language models. We have a lot of other tools we're starting to think, look to employ in the data, but also things that are a little bit more subtle. Like right now, CPATH has been amalgamating and standardizing novel data types like digital health technologies. We heard from patients of how valuable that is, and then we've heard from regulators that we don't see this data because it ends up being exploratory. And so we wanted to create a resource so that all sides could begin to explore this data and understand how the time commitment, for patients wearing these in clinical trials can manifest evidence that might lead to treatment approvals and ultimately treatment decisions. The other element to this is that I was on a call recently with the rare disease community, and we're getting ready to start a project. And one of the things that they said just echoed in my mind. And one of the things that they had been approached over and over again by companies to ask them questions about like study design, about things that were important to them. And their first question was, how will my data be used? And this study was important because it was a qualitative study, lots of interviewing, lots of conversation with these, a lot of time commitment and things. And they've said, we're really tired. Each individual group is coming to us and asking these questions, and really it's not shared. And we want this to be shared because, us, having it, put away by an individual group is not helpful. And so we've got a couple projects that really focusing on qualitative data. And obviously you can say with diseases that have short longevity, capturing that is an incredibly valuable resource, not just because of the time commitment of the individual, but the enduring use of this in multiple stakeholders. And so, we've been working a lot on qualitative data. I think, as the N of one and precision medicine elements, understanding long-term predictive tox and preclinical translational requirements, we're moving in that direction. And I know in the recent RISE programming, we began to talk about that, and I'll put it more to come, and I'm sure we'll have a follow-up podcast on some of that, because as we begin to think about things like the plausible mechanism pathway and understanding how that contributes to supportive evidence, and as Klaus's earlier comment, there's a lot of foundational pieces in rare diseases that we can learn about based on their pathophysiology, but they also, those same foundations can predict drug toxicities and potentially predictive efficacy. And so, at CPATH, the data elements will continue to evolve along with the regulatory strategies that you're starting to come out of the process. And I'm sure we'll have additional podcasts that are talking to because it's an extremely exciting time. And CPATH is, trying to work hand in hand with regulators to provide those resources and such in those partnerships to be, as incredibly impactful as it is in the previous 20 years. One thing I want to really reinforce is a call to action. One of the things we spend a lot of time at CPATH is data outreach and trying to obtain data so that we can learn about diseases and produce those ultimately in those solutions that we provide. So I want to encourage everyone to reach out to CPATH about sharing data and how you can share data and become involved in our programs and such, because obviously amongst those 10,000 rare diseases, we're always exploring nuance. And so we love to work with different communities and to support them. And one of the foundational pieces of that is data. So data sharing, I definitely wanted to emphasize the importance of that. And we encourage everyone to reach out to us about that.
Excellent. Well, Collin, thank you so much. This was a fantastic conversation. I really enjoyed it. And we hope to see you in a future podcast with more to report and more to share on the impact of the platform and the transformations that you're leading in accelerating drug development for rare and orphan conditions. To the audience, thank you so much for listening, and we'll meet again at a future episode. Thank you so much.
Thank you.
Did you enjoy this episode? Share it with a friend or colleague, or leave a review on iTunes, and help others discover and support our mission. We are welcoming guests with a range of experiences and viewpoints. The views expressed belong to the guests themselves. Learn more about Critical Path Institute at cpath.org. That's c-path.org. Stay tuned for our next episode coming soon, and thanks for listening.